and chest will be discussing in detail. And in particular, you may be asked either in the Viva or in the short notes about a tension pneumothorax, Flail chest. Short notes are an essay on management of splenic injury, or a short notes on diaphragmatic injury, and the various MCQs based on this particular thing, especially the X-rays, radiological imaging. So it's a very, very important chapter as far as a budding surgeon or clinicians are concerned. So let us spend another 50 or 60 minutes usefully on this very important topic. And as you already know, most of you, if you are not joining as of now, you could go and see the same SEM surgery masterclass module. All the 16 modules we have done so far are available in the YouTube. And this also would be available as soon as we finish today's discussion. But of course, nothing like having a one-to-one chat now. And you can post a question either directly to me or by chat box, so that I can answer those and address all your queries as we go for today's topic. And as I said repeatedly, our approach is a symptom-based approach. So here we are going to see few patients who come following fall from a height or after road traffic accident with one of these 4 different types of injuries. There we are going to just visualize that patient. Okay, like a template. If a patient comes, what will you do first? A primary survey. Then how will you resuscitate the patient? And how will you investigate the patient? Like that, we will be going as per the need by what I call an advanced trauma life support procedure. That is ATLS, standardized program. So you need to think like a trauma surgeon. From henceforth, for the next an hour or so, you are like a surgeon, especially working in a trauma ward. Okay. Now let's see the chest and abdominal injury in particular. We are not going to discuss anything about the head injury, but because that itself is a big topic, I leave you to read yourself. If time permits, after the 30th module, let me just give you an idea about the important aspect of the head injury, because head injury is also an equally important essay for all of you. Just remember that. Coming back to the chest and abdominal injury, as you can see here, apart from the road traffic accident, a fall from a height, or even in a sports like skiing and other high-speed velocity sports, or an assault, all these things can give rise to a blunt injury both to the chest and abdomen, because of the mechanism is basically these 3 or 4 things, either a bursting force, shearing force, crushing force, or a penetrating force. You will be wondering what is this, because you need to understand exactly the mechanism of injury. Imagine if you are a driver of a car and you are at the driver's seat. If there is an injury, especially if you are not wearing a seat belt, what will happen? You will be literally crushed between the steering wheel and your chair you are sitting, isn't it? So it is a crushing force. So you will have a crushing of your sternum, and also you will be having a crush injury to the mediastinum, especially the aorta, and also further injuries. So it is a crushing injuries. For example, if you are a pillion rider in a high-speed two-wheeler, and if you are thrown off the bike, what will happen? You will be over the road for several yards, and there will be a sudden deceleration injury. That is a shearing force. Shearing force is where the mechanism, you are just going on the floor like that. So because of that, wherever there is a mobile and fixed organs, it will be torn like that. For example, DJ flexure, iliocecal junction, or arch of aorta becoming a thoracic aorta. Wherever there is a junction of a fixed organ to a mobile organ, there is a shearing force. Okay, so because of that, there could be an avulsion type of injury can happen. Shearing force also is responsible for various avulsion injuries in orthopedics also, you learn so. Bursting pressure is because of the pressure itself. Quite common, especially if there is a run over accidents. Some big wheel, a tire run over you, for example, and because of the increased pressure, there is an increased intra-abdominal, increased intrathoracic pressure that causes an injury. A classical example is a diaphragmatic injury or a rupture of the stomach or rupture of the full bladder. They are all bursting force. Rarely, some impaling objects, because of the sharp, some parts of your car or something can penetrate deep in you. Same thing could happen even in a penetrating injury, in a bullhorn injury, for example. So they are penetrating force, which obviously causes like what a stab injury, like a knife or a bullet injury can cause. So bursting force, shearing force, crushing force, penetrating force can give rise to this. And when a patient comes, because of these types of injuries or high velocity injuries, they have what we call a polytrauma. So you need attention of at least 3 or 4 people, both medical and paramedical. That is a team approach. As an anesthetist, an emergency physician, he has to take care of the airway of the patient. As a general surgeon, I may have to take care of the patient chest and abdominal injury. A neurosurgeon come and take care of the head injury. An orthopedic surgeon will coming for the pelvic and also the peripheral long bone injuries. So they have to do a simultaneous attention to the patient. It is not sequential. It is not getting one person's opinion, then the next person comes and 1 hour later. No, because the time is in essence, patient would succumb to the problem in matter of few minutes, if not hours, because of A, B, C. That is airway, breathing, and circulation problem can kill a patient in a matter of few seconds. So that's why we always say the first 1 hour of the trauma is a golden hour. The treatment should start, especially right at the time, the place of the accident itself. That's why now we train our ambulance driver also or paramedical personals in the first aid, how to intubate, how to take them and put them in the spinal cord without causing any injury to the cervical spine, I to transfer them as quickly as possible. All those things been taught not only to the doctors but also the paramedical persons, because the time is very important. Never forget this important thing. There is a golden hour because people can succumb within an hour because of this A, B, and C. Okay. So let me concentrate now for the next 30 minutes on blunt injury trauma. And accidents because of this, and also if you're a pillion rider or if you're sitting in the back seat, you can be thrown out of this car because you are not wearing a seat belt. So take it from me, all of you, please wear a seat belt. When a patient comes to the emergency, what we do, as per the advanced trauma life support protocol, the patient is literally wheeled in. The paramedical person will give you an history that is called ample history. In other words, unlike a conventional patient coming to the general surgery or medical ward where you elicit the present history, past history, personal history, family history, then inspect, palpate, percuss, auscultate, investigate, then you treat. Here, by the time patient will be very moribund. So it has to be in a matter of a minute, you should start doing the treatment. That's why the history should be very concise, already very often taken by the appropriate persons. Could be you like a junior doctor or could be a paramedical person. Very important, 5 important things in the history as far as the trauma patients are concerned are given with a mnemonic ample. That is allergy, because very important before you inject any drugs to the patient. You want to know whether the patient has any antibiotic allergy. Medication, whether the patient is a known diabetic on insulin or whether the patient is already taking clopidogrel or warfarin, because those can give rise to increased chance of bleeding complications. Past medical history, very important, because we like to know the patient's comorbid status before we advocate any treatment. The last meal, because if you are going to decide about any surgery or decide about putting a patient on intubation, you like to know whether the patient has a full stomach, because very often you tend to go for a ride after a full meal. That time there is a risk of aspiration is so high. So you need to know the last meal. Minimum 6 hours is ideal, not to have the risk of aspiration whenever you do any anesthesia procedures. Of course, the mechanism of injury can be understood if you can get a history not only from the patient, but the person coming along with the patient who witnessed the accident. He will tell, sir, I saw him thrown out of this vehicle, okay, or he has been extricated from the vehicle, like that the fireman or the ambulance driver or the witness or the neighbor, somebody can give you events surrounding the history. That gives you an idea about the mechanism of injury, and accordingly, you can see the severity of injury, you can guess. Once you have enough history, immediately you see the patient. The treatment of the patient is a 6-step process. This is a very important slide, you memorize this. As soon as a patient comes, very often in a massive accident like a bus full of passengers caught in a fire or had an accident, there are 40-50 people will be coming all of a time to the patient, to the hospital. So what have to have been done? You need to triage the patient. In other words, you need to know who is a more serious patient, who is a less serious patient. The triage can be done both by the senior nurse and also by a doctor, who will tell, okay, this patient goes to emergency, this goes to the observation ward, this patient goes to ICU, like that. Once the triage has been done, then you come and do what I call a primary survey. That is a quick glance to look for A, B, C, D, E. Let us come to that in a minute. Then as you see, you treat. That is very important. If you see a patient is struggling to breathe, you address the problem before you go on look for C, that is circulation, whether the patient. So it's very important thing is, each important survey should be followed by a resuscitation measures. That's the way we do. Next, what we do, once you've done primary survey, if the patient is stable, alive, then you go for head to foot examination systematically. That is called a secondary survey. Then according to the survey findings, you go for investigation. Then you ask for a definitive either a surgical or medical care. So this is the way we do. Okay. Next, this is as far as a chest injury is concerned. As you can see here, a patient is brought in. Look at the airway, whether the patient is having a stridor. Stridor is, what is stridor? It is a difficulty with inspiration. Inspiratory stridor is more important. If you take a deep breath, you can hear the patient is having some foreign body or some secretion or something is causing obstructive or labored breathing. You clear the obstruction, very, very important. Breathing, if the patient is having air hunger, hyperventilating, or increased respiratory rate, normal respiratory rate is 12 to 16. If it is more, there is a reason for increased respiratory rate. Carefully, if you inspect, one part or one side of the chest may not be moving like the other side, decreased chest movement. Then it will give you, or look at the trachea, deviation to the other side, or put a stethoscope and see whether there is a breath sounds absent or present, or if there is a time, or if you can do a percussion also will tell you. So by inspect, quickly palpate, percuss and auscultate and come to a conclusion, the reason for the breathing difficulty. Is it a pneumothorax? There is air in the pleural cavity. Hemothorax, a blood in the pleural cavity, or what else is a cause for the breathing difficulty? Accordingly, you manage. The third, of course, is a patient has an obvious bleeding outside, that is called external bleeding. For example, there is a cut injury here with a jugular vein, external jugular vein pouring blood. Then you can just put a pressure bandage control, or even you can place the hand to keep a control while you are thinking about suturing that wound. So that is an external bleeding. But you should realize there are other reasons for bleeding. It can be considered as under the category of internal bleeding or a concealed bleeding. What do you mean by an internal bleeding or a concealed bleeding? Imagine a patient has a chest injury. If there is a hemothorax, a large quantum of blood can be accumulated in your pleural cavity. Or if you have an abdominal injury, Nearly a liter of blood can be accumulated in your abdominal or peritoneal cavity because of the injury to the spleen or a liver. Or if you have a child who have a fracture, run over injury to the leg, there will be long bone fracture like a femur. Nearly 500 ml of blood, a pint of blood can be accumulated there along the long bone. So those can give rise to a hemorrhagic shock. Patient will be pale, patient will be hypotensive, patient will have a tachycardia. The three classical signs. That's what you look for in circulation. So A, B, C. Of course, D is dealing with patients, any neurological problem. C, you have to go under E. Deal with the exposure. You expose a patient and examine the patient. But these three are very, very important. As far as the chest trauma is concerned, I want you to concentrate on 6 serious situations I'm going to discuss one after other. What are those 6 serious situations? Tension pneumothorax, open pneumothorax, flail chest, massive hemothorax, diaphragmatic injury, aortic or cardiac injury. So those 6 are vital injuries. If you misdiagnose, matter of few minutes, patient may die even. So that's why these are all the 6 important injuries one has to write under the primary survey. Primary survey for chest, I would try to recognize one of these 6 or all of them if they are present, and then treat them as you see. And most of the time, these people, either during the procedure or at the end of your primary survey, would require a chest x-ray, and most of the treatment would be an ICD, intercostal drainage. Let us go by one. Okay. The first important thing is a tension pneumothorax. I'm sure all of you would recognize if you have an injury to the chest, either there is a small hole in the lung or there is a small injury to the chest wall like a rib. So there is a one-way valve. In other words, the injury of the lung or a chest wall is in such a way, there is during inspiration, air goes in normally. That air comes out of this hole here or gets through the chest wall here and starts accumulating here. During expiration, the hole, like a shutter, closes, okay, because of one valve mechanism. So air only keeps on collecting only during inspiration. So after few episodes of inspiration, what will happen? There is a pent-up of air. Air is collected in the pleural cavity under tension, under pressure. All of you should know by this time, the pleural pressure for most of us normally is negative. That's why you are able to suck in air. That's why there is a venous return. So negative intrathoracic pressure aids in proper breathing, proper circulation. If you have a positive pressure, it compresses not only the lung, causing the lung collapse, it compresses the superior and inferior vena cava. So venous return is compromised. So the patient has decreased cardiac output because of the decreased venous return, hypotension. So cardiac respiratory collapse leading to cardiac compromise. And also the whole mediastinum, because of the high pressure here, will be shifted to the other side, compromising the other lung also. So this is a very serious situation. As you can see here in this X-ray, you can see a collapsed lung here. As you can see the right side, there is a hypertranslucency here. There is a tension pneumothorax on this side. Normally, the right dome of diaphragm should be just below the 4th or 5th intercostal space. Somewhere here, it is pushed down. See, both are on the same side. Normally, the diaphragm on the right side should be somewhere here. So pushing of the diaphragm, pushing of the mediastinum, and also collapse of the lung, and there is no bronchovascular marking like here. See, you can see the bronchovascular marking, all are absent because it is only air-filled pleural cavity. A classical tension pneumothorax. Tension pneumothorax, you should all realize, is a clinical diagnosis. But of course, if there is an X-ray available, or like this case, a CT available, like here a CT, showing this is the right side of the patient, left side of the patient, left side you have the heart and the left lung, the right side lung is collapsed and there is a dark air. Air is also black in color, okay, as far as the CT is concerned. There is a mediastinal shift up to the opposite side, okay. So as I said before, A tension pneumothorax, can it be diagnosed clinically? Yes. Patient is breathless, patient is cyanosed, patient has increased respiratory rate, and the patient has a severe right-sided chest pain, especially if there is a right pneumothorax. And if you just inspect, there is a decreased movement of the right chest. If you percuss, there will be hyperresonance on the right side. If you auscultate, there will be decreased breath sounds on the right side or absent breath sounds. And if you do take a BP, the patient's blood pressure will be low and patient will be having engorged veins because of the circulatory compromise. So this is actually minutes count matter. So within few minutes, if you're not able to diagnose, these people die. So what I ask you to do, remember to do one of this first. First, you take a venflon, a broad and what we call a gray venflon. Okay, put it just in through the intercostal space, the second intercostal space in the mid clavicle line. Doesn't matter because this is the easiest side to know. If it is the left side tension pneumothorax, go through the left side. If it is the right side, go through the same space on the right side. Go straight in, take the needle out, and only the outside sheath is there. Through that, the air under pressure will come out. So air pressure will be equalized to the atmospheric pressure. In other words, what was a tension pneumothorax will become close to our ordinary pneumothorax. Okay, simple pneumothorax. So the tension alone is relieved by this. How will you know? As soon as you put in the needle and take that needle out, then you will see a hissing sound coming. That air, pent up air, collected air will come out under pressure and it will hissing noise. And that is what first thing you do. That is called a needle thoracentesis. That is the first thing you do. Where you do, how you do, what do you have for this to do is a venflon, a broad, a big venflon, okay, gray venflon. Next is a underwater seal, ICD, intercostal drainage. Immediately you have to do in all patients with the tension pneumothorax. We'll discuss in detail later. All we need to do is put a tube into the pleural cavity. The tube is connected to this water, okay, an underwater seal. So that whenever the patient is breathing out, breathe out, air here will be breathed out, okay, like that. It comes like a bubble. Take you breathe in. As you breathe in, from outside air will try to go in, but it will not go. Only the column of water will rise. So in other words, every time when the patient breathes out, that lets the air out of the pleural cavity, and there is no way the air is able to get inside. In other words, one valve here, it's made into with another one valve mechanism outside. We are trying to address this. So water column in the underwater seal acts like a one valve, so that all the pent up or collected air is slowly, surely removed a matter of few minutes, and the patient's pneumothorax is completely relieved. So a tension pneumothorax becomes simple pneumothorax, a simple pneumothorax becomes no pneumothorax. So that is the treatment for this condition. And next condition is an open pneumothorax. What do you mean by open pneumothorax? Because this is a very rare condition. Not many students would have seen. Nowadays, it's so common, especially when a patient is actually literally thrown out of the car and dragged in the road. So you can have injuries like this, and you can have an open wound. Or if you have a bullhole injury, imagine there is a big wound right through the pleural cavity like this. So air goes in and out, in and out. So as a patient breathes in, through the trachea, air gets in, through the hole also gets in. Okay. And when he breathes out, air from here also goes out, air in the pleural cavity also goes out. But because of the to and fro, there is no air exchange within the lung. The lung remains collapsed. There is an air, even though it is under atmospheric pressure, it is not like a tension pneumothorax. It is actually causing us so much of exchange of air here, and the patient technically has only one lung breathing. The other lung is not all working. So because of that, patient will go for air hunger and die. So immediately what you need to do, if at all, while you're waiting for the ICD is a treatment, that is intercostal drainage tube placement, you can do one small dressing. Like that is a three-way occlusive dressing that is called. What is three-way occlusive dressing? You put a dressing where you can see the wound and stick three borders of this margins of this wound like that, and this particular part, it like a flap valve, it just let loose. So whenever the patient breathes in, air cannot get in because it shuts in like this, okay, like a flutter valve. And whenever a patient breathes out like this, air can come out and it can just escape through this flutter like that. It will flutter like this. And during inspiration, expiration, like that it will go. So this is a very simple device. So needle thoracentesis for tension pneumothorax, three-side occlusion dressing for an open pneumothorax are the first aid you need to learn. But in both cases, one definitive treatment a surgeon will come and do is ICD placement. Okay, so the difference is this. This is the tensor pneumothorax and this is the open pneumothorax. Okay, in other words, a tensor pneumothorax, the pleural cavity pressure is more than the atmospheric pressure. Open pneumothorax equal to atmospheric pressure. Okay. Third important condition is a Flail chest. What is a Flail chest? Imagine you have a fall from a height at 20 feet or 30 feet height, you are painting a wall, you suddenly have a fall. So what will happen? Unexpected falls, multiple fracture ribs. So see all these ribs, 1, 2, 3, 4, 5, 6, multiple ribs fractured at multiple places. So this part of the segment of the chest wall behaves paradoxically. That causes pneumothorax and also respiratory distress. Let us see it. Definition. A Flail chest is a condition wherein two or more ribs fractured at two or more places. Like this. Here 1, 2, 3, 4 ribs fractured at least two places like that. So this is like a autonomous. It is behaving on itself. So if this is called a Flail segment. In other words, the chest as a unit expands and also during expiration, it comes back. But here, because this particular Flail segment will behave just opposite to the other component. It's like a party within a party. It will just do opposite to what the party is intended to do. So this is what we call a paradoxically it will do. I'll come to that paradoxical movement in a minute. So because of that, and also because of the impact there, not only the ribs are fractured here, underneath that lung also goes for a pulmonary condition. That also in addition contribute to the respiratory failure. Okay. See, this is what will happen. During inspiration, expiration, what happens is just opposite to what should happen. What do you mean by it? For example, normally you and me, when we take a deep inspiration, the lung expands. Okay. But here, because this Flail segment is a separate segment, when you breathe in, because of this negative pressure, this particular Flail segment is sucked inside. Okay. That during expiration, what will happen? Because of the increased positive pleural pressure, the air comes out like this. But here, the Flail segment is pushed out. So instead of all other things trying to do, pushing the air outside, this is itself is going out. So only the Flail segment is going in and out in just opposite to what others are doing. So that way disturbing what should be done. The air exchange is greatly compromised. So the patient goes for a respiratory failure. So this is what will happen. So what do you do for a treatment for these people? Of course, you need to do an ICD because often they have an associated pneumothorax. Next, because of the multiple fracture rib, they have a lot of pain. So you need to give them what we call a thoracic epidural. So this is the spinal cord. So you put the patient on the side, go through the thoracic vertebral space, intervertebral space, go into the epidural space and inject the analgesics so that the patient has a pain-free, so he can breathe better. If that is also not settling, then you go for what we call a mechanical ventilation or assisted ventilation with a machine. with a positive end expiratory pressure. That is a PEEP. You are doing an internal stabilization. So the lung will from out inside will just try to avoid the paradoxical movement of the flail segment. Okay, so this movement is avoided by internal splinting. In other words, you expand the lung by mechanical ventilation by using the technique called a PEEP. What is PEEP? As I said, positive end expiratory pressure. Normal lung is different, like here. A well ventilated alveolus, you can see this, okay, saturation of the alveolar oxygen. Whereas here, consolidated lung, because of conduced lung, there is no air exchange. So here there will be less amount of oxygen. So here, if you see this particular area, the oxygenation is very, very little. So the mixed venous admixture here, it will carry a less amount of oxygen. Okay, so oxygen exchange should know as a short notes is intercostal drainage. What do you mean by intercostal drainage? Putting a tube in the pleural cavity, joining it with the underwater seal. Like here, we have already seen the indication tension pneumothorax, open pneumothorax, flail chest. Of course, the fourth one I'm telling you in a minute is a massive hemothorax. So here, how we do it? What are the complications? Especially if you don't do it properly, you can cause a lot of injuries. We'll discuss all these things. Listen to this particular thing. I'm sure you will be able to see this video.
There are 10 ideal steps for ICD. Prior to ICD, we should have the ICD set open with the necessary equipments, suture material, and a large chest drain and the underwater system with the sterile water. A small incision is made in the upper border of the fifth rib in the fourth intercostal space in the mid-axillary line, and a blend dissection is done with the index finger going through the muscles, intercostal muscles and pleura, and actually my finger is inside the pleural cavity, and while holding the finger like that, the tube is taken and it's inserted. You should see that only the tube alone is inserted, not with the forceps, and it should be directed up to the apex, and it should be up to the level of 10 or 12 centimeter, not less or more. Then it has to be fixed, and here is one way of fixing the chest drain, very important step. And the drain then is connected to the underwater seal, a bag with a sterile water poured to the level so that the tube opens into a water column, and you should soon see bubbles of air coming out, suggesting that it is in the right place and the ICD is working. The surgeon is just checking the tube is secure and is connected, and now as you can see, the whole system is in view and it is functioning. If it is too low, then you may enter the abdominal cavity. If it is too anterior, you may have to go through the chunk of muscle. So the triangle of safety is a triangle between the anterior and the posterior axillary line and the upper border of the fifth rib.
As you saw that, so there is a very, very important small clip I wanted you to understand, and you have seen step by step. It is self-explanatory. What you should know is, you should know exactly when you are making an incision, it should be in the triangle of safety. In other words, it should be just above the fifth rib. If you come below the fifth rib, then you may enter the liver, for example, or 7, 9, 10, 11th rib. You can see on the left side, the spleen is there. You can injure the spleen. If you come anteriorly, you know, there's a lot of muscles. Pectoral is major and minor. It's very, very difficult to enter. So this is the triangle of safety is on your axilla, above the fifth rib, between the two axillary, anterior and posterior axillary folds. It's a very, very important place. The second important thing you need to know is you need to go through whether the upper border or lower border of the rib. You should all know by this time where the intercostal blood vessels and nerves are running. If you know exactly, and then you know where you should not go, because you should go only on the upper border of the rib, not through the lower border of the rib, because the lower border of the rib is very close to the blood vessels and you might injure and cause iatrogenic hemothorax. So this is the second important thing you should realize. Okay, and if it is only for a pneumothorax, the tip of the tube can be placed in the apex. If it is for a hemothorax or a fluid, it can be placed here towards the base. So that is up to you.
There are 10.
And as I said before, this is the way it should be. During expiration, patient, because of the increased pressure here, slowly the air comes out as a bubble. When the patient takes deep breath, air will not get in because it's a closed system, and also even if the air gets in, only the water column will be pushed up like this for about a couple of centimeters. The column movement is the only indication it is working, but there won't be any chance of air getting inside. So air keep on emptied, or after a day or so, all the air will let out. Then after a few days, you do a chest X-ray, check X-ray, make sure a well expanded lung. Then you can remove the tube and seal that hole. The hole will heal by itself. There's no need to take any further suturing to close the hole. There's a very simple life-saving procedure. Every resident have to see, do, and master this procedure. Okay. And this is another case of massive hemothorax. As you can see here, there is a dense, instead of the radial lucency, here there is a density with the obliteration of the corsophrenic angle. And as you put the ICD in the triangle of safety, you can see a blood coming out. So this is the hemothorax. This is another condition wherein you can see the whole heart. There is something like a cardiomegaly. It is actually because of the injury. There is a cardiac tamponade. If there is a bleeding inside the pericardial cavity, there is a collection of fluid or blood here, then it gives rise to a peculiar combination of three important combinations. There is a low BP, high jugular venous pressure, and if you just auscultate, there is a muffled heart sounds. That is called a Beck's triad. Very, very classical thing. And fifth important thing is you need to realize sometimes, especially I told you, run over accidents, sometimes because of the increased abdominal pressure, there will be an injury to the diaphragm, especially on the left side. So the abdominal organ can herniate into the left side chest wall. That is called a diaphragmatic hernia. So how will you diagnose a diaphragmatic hernia, especially traumatic diaphragmatic hernia? That is elevated diaphragm. If you just see a patient will have a classical three important things. One, of course, is he'll have a respiratory distress. Why? Because all the intestines here gone into the chest so that the lung is collapsed. So he is breathing only on this lung. Not only that, here, because of the presence of the lung, the intestines, the mediastinum is also pushed to the other side. So you'll have what we call a pseudo-dextrocardia. And if you start auscultating, then there will be absence of breath sounds. Occasionally, even you can hear some vowel sounds in the chest. So there's a classical finding in a traumatic diaphragmatic hernia. But the most important thing for all of you is when you suspect diaphragmatic hernia after RTA, road traffic accident, anybody calls you, I see the chest X-rays are. If the chest X-ray shows the elevated dome of diaphragm, that is a ruptured diaphragm. Because all of us know the diaphragm actually, the left dome should be here, right dome only will be higher up. Here you can see just opposite here. So this is a raised left dome of diaphragm. Okay, and it is indirect. Sometimes you'll see even all this stomach and everything going up, but this is the commonest finding you should never forget. And if you do a CT, there you can see a CT. This side is okay, but this side you can stomach is herniating into the chest wall. You can see on the left side, large diaphragmatic rent, like here, for example, large injury to the diaphragm, elevated dome of diaphragm with a fluid-filled stomach is there. So like that, you will be able to, and you may all know very simple thing, why diaphragmatic hernia, traumatic is more common on the left side, because the right side, the liver is there, it protects any herniation of any solid viscera. But sometimes it can also happen. A right diaphragmatic rupture is rare. Okay, whereas a left side diaphragmatic hernia is more or less rule rather than an exception. Coming to the last very important complication or a vital complication which can give rise to death even if you don't recognize is A widened mediastinum, if you are able to see in a chest X-ray, that means the patient would have got injury to the ruptured thoracic aorta. See, for example, this is the arch of aorta now becoming a descending aorta, and these are the vessels. And here the mobile part is becoming a fixed part, like ligament. Okay, so in this area there may be a shearing type of injury. There is a deceleration injury. I told you already. Whenever suddenly you're stopped, okay, the moving vehicle becomes a stationary vehicle, like a hit on a tree or something like that. You go like that, it come back. So that injury causes, okay, a mechanism called shearing force. And wherever there is a stationary and fixed organs in our body, they go for this. The common things are injury to the aorta, so thoracic aorta. Second is a pancreatic injury also can happen. That is, pancreas goes for a torsion, the tear of the duct, or DJ flexure, ileocecal valve, they can go for a torn. So all these things are very classical example of shearing type of injury. What are the indications for thoracotomy? Like a laparotomy, what we do to open the abdomen to look. Thoracotomy, make a big incision to look into any injuries and treat during trauma. Very rarely we do. You take it from me, the only one common life-saving procedure most of the people will require is, of course, ICD. Occasionally, if a patient has a penetrating injury to the heart or great vessels, or if the hemothorax is so severe, continuous, you have to go in and control the bleeding. Or if there is a major the bronchial tear causing a persisting pneumothorax, or of course, this last case, what we have seen, a diaphragmatic rupture, then there is an indication for a thoracotomy. So these are the 4 indications for surgeon's role. All other thoracic trauma can be eminently managed in the emergency department by using a simple ICD procedure, which is a life-saving one. I told you already, once you've done a primary survey, you do a secondary survey, wherein you see the patient head to foot. Here, for example, you see a patient having a fracture of the sternum, manubrium, and this is sternum. Or sometimes even the body of the sternum, there may be a fracture there also. So these can happen, and treatment is most of the time is a conservative treatment. So this finishes the blunt injury chest. Let us move on to the blunt injury abdomen. If there is no any questions, we'll move on to the blunt injury abdomen. I'll just give a little break, stop sharing, and then if anybody wants to ask any questions, you can unmute yourself and ask me. Yes, anybody wants to ask me? Priyanka, Arun, how are you all doing today? Jakan?
Sir, good
Yes,
morning, sir.
Kadiraman. Yes, good morning.
Sir, is there any significance in differentiating tension pneumothorax from open pneumothorax, sir, in casualty, sir?
Yes, of course, open pneumothorax patient will have an open wound. Chest wall will be having an external wound. That is a very, very important thing. But having said that, open pneumothorax, tension pneumothorax patient also can have. But the only thing is how severe patient's hemodynamic status is compromised. It is more compromised as far as the tension pneumothorax is concerned. The patient will be hypotensive. Patient will have engorged the jugular vein. These are very classical presentation, especially in a tension pneumothorax. And the patient will be relieved as soon as you put the needle, and the hissing noise comes after needle thoracentesis. You can make him like from a tension to either open or a closed pneumothorax. So tension is more life-threatening than open pneumothorax. But what is important in open pneumothorax is you need to seal the open wound. Just to putting an ICD alone is not enough, because that is continue to have the problem. So that's why the importance of the sealing the wound in addition to ICD. That's why this particular entity is brought into the limelight for all of you.
Okay, sir. Thank you, sir.
Any other question? Karthikeyan, how are you doing?
Yes, sir, I'm fine, sir.
Good. It's okay now. So I made it fairly simple in the sense 2 or 3 points in each, because as I said, this is an emergency situations wherein there is no essay writing on pneumothorax or hemothorax. That all you do in medicine. Here, as a surgeon, you just make a diagnosis by like a mathematics and treat. The treatment is essentially doing a bold ICT. What to do and how to do is what you need to all witness. So you see the video I've just posted, and also there are several videos available in YouTube. Please go and see. And if you are able to, lucky enough to witness one, especially being performed during your residency, even better, because that is a next to the venous access, like putting a vent on. This is a very, very important life-saving thing you also learn and master. Okay. So if there is no further question, let us go on to the chapter again. Let me just go. So blunt injury abdomen. Okay. So this is going to take another 30 or 40 minutes. This is different from the shotgun injuries, penetrating injury, but to some extent that also can be covered here at Sol. Imagine a patient after road traffic accident is coming, wheeled in and lying in the bed. Now you have this particular patient. How will you going to examine? You are going to do a triage, then primary survey, resuscitate, secondary survey, investigate, then definitive treatment. That's what you need to write first. Okay. In the primary survey, like in chest trauma, here there are 5 life-threatening injuries we need to recognize during primary survey. What are they? Presence of blood in the peritoneal cavity, hemoperitoneum. Evidence of hollow viscous injury, that is pneumoperitoneum. Any obvious injury to the abdominal wall so that the bowel is hanging out, evisceration of the bowel. Or any penetrating injury with the object still lying there, like a wooden piece or something like that, impalement injury. Or there is only the entry wound, exit wound, like a bullet injuries or a penetrating injuries, like that. So all these things you need to recognize. In other words, any examination of chest, abdomen for that matter, you not only see the patient from the front, also having the habit of turning the patient, log rolling. Why log rolling? Because when you turn the patient, you have to ensure there is no twist in the spine. Otherwise, you can create what we call a second accident during the examination. Cervical injuries, spinal injuries which were partial can become a complete if you're not taking due care. So at least you need to have 2 more additional people to help you, so that like a wooden piece, the body is turned to one side. Examine the back also to see any external wound. Sometimes you will be surprised to see another stab injury or an exit injury on the back also. So examine front and back. Second important thing is coming to the hemoperitoneum. What is hemoperitoneum? Blood in the peritoneal cavity. It is a sign of solid visceral injury. Very simple. Okay. If you see a patient, ultrasound shows there is a 1 liter of blood, if the sonologist says, that is coming either from the spleen, liver, or some other solid viscera. The other viscera are mainly essentially retroperitoneal, like a pancreas, and also next solid viscera, of course, is the kidney. So they cause more of a retroperitoneal bleeding. So essentially, a hemoperitoneum is either of these 2 conditions. Spleen by far the commonest organ injured as far as the abdominal organ is concerned. Next is only the liver. But sometimes hemoperitoneum can happen also from the tear from the mesentery. Okay, that also you keep in mind. So 3 things can give rise to splenic injury, liver injury, and also tear in the mesentery also can give rise to bleeding. Coming to the next important thing, how we manage a hemoperitoneum. If you say the 3 things I have said, liver, spleen, and mesenteric tear, provided the patient is stable, there is no rush to operate on these people, because the abdomen, like a tamponade, is trying to contain the bleeding. So the patient, provided patient is not becoming more and more hypotensive, the hemoglobin level is not dropping any further, you have to wait, do more investigation like ultrasound, CT abdomen, or other investigation for undergraduates, I would say, is a diagnostic peritoneal lavage, DPL, all those things. and try to manage these patients if possible without surgery. Why? Because you can't remove a liver. All of us know. So liver has to be sutured. What about the spleen? Spleen also better you preserve, especially in a child with a splenic injury. That is called a non-operative management of spleen. What about adult? Adult also, we try to preserve the spleen if possible. Because even though spleen is a dispensable organ, unlike a liver, still it has a function to do. At least immunity, immune function of the spleen, and also spleen, we know, is a burial ground for all these dead and dying red cells, platelets. So you need to know the spleen is there as one of the important reticuloendothelial organ with a lot of immunity, optimization. So if you don't have spleen, there are problems. The problems of infection or proneness of infection by capsulated organisms like a pneumococcus, meningococcal infections, because you need to have a substance called opsonin. So opsonin is produced by spleen. In the absence of spleen, there is no opsonization. So because of that, there is no effective phagocytosis of these capsulated organisms. So patient will go for a pneumococcal septicemia. That's why we always say patient requiring elective splenectomy, they have to have a vaccination against these organisms beforehand. But we are now talking about the trauma situations. So here, if the patient's life is in danger, if the only way patient is going to survive by sacrificing his spleen, by all means you do remove the spleen. But of course, you post-operatively give the patient a pneumococcal vaccination. So vaccination, even though ideally given beforehand, in these trauma situations, you may have to give after procedure. That is the one thing. But as I said, now the current concept in 2020 is essentially a non-operative management of liver and spleen. But if the patient is hypotensive, continue to bleed, then you have to do a laparotomy. Spleen, you remove. Liver, you suture. Very simple. Okay. What investigations we can do while we are thinking about whether to operate or not? There are 4 investigations we have. Ultrasound abdomen, CT, DPL, diagnostic peritoneal lavage, of course, a diagnostic laparoscopy. It all depends upon which hospital setup you are in, who is the expert available, and what are the limitations of this test, all these things. At your level, what is enough to say, we do ultrasound in all trauma patients. That is called, all of you know, fast scan, focused assessment of with sonography for trauma. So we see importantly focused. So even an emergency physician or emergency doctor should know how to do a fast scan. For example, if a patient comes with an injury to the abdomen, you want to know the patient has a free fluid in the peritoneal cavity or a thoracic cavity or the factor, the pericardial cavity. You do this. Put 1, 2, 3, 4 probes on these places so that you'll be able to see exactly the pericardial, perihepatic, perisplenic, and pelvic. So this one, the first one is important thing, that is the perihepatic. So you are able to see the liver, kidney, the Morrison's pouch is somewhere between the right kidney and liver. Any fluid you'll be able to see. Next, of course, is a heart. That is by probe here. And the next one is, of course, this probe here, this perisplenic. You'll be able to see the spleen and any hematoma around the spleen, left kidney. Then the last one is in the pelvis, bladder with a and uterus, is any fluid around. So like that, you'll be able to see clearly is there any bleeding or any free fluid. Very, very simple, effective way of doing things. It's a quick procedure, non-invasive, able to see the fluid or any injury to the liver or spleen. But you should be an expert in doing it. And one important negative point you should all know is injury to the small bowel, large bowel cannot be diagnosed by ultrasound. For that, we need a CT, because CT is the best one. I told you already, CT is important for all trauma. CT is important for all tumor cases because it gives you a TNF staging. And the CT is very, very important for any retroperitoneal diseases like a pancreatic diseases, aortic vessel diseases, and a renal vessel diseases. All these things you can assess better. So any patient with a hemoperitoneum, whether they are actively bleeding, as we see patient is bleeding, there will be an extravasation of contrast. We can very easily witness. Okay, that is called the blushing of this bleeding blood blushes. So hemoperitoneum alone is not sufficient. You should know whether the patient has an active bleeding. So contrast CT will tell me whether the patient is having active bleeding. Second, you will be able to see the retroperitoneum very well, like a kidney, pancreas can be assessed. Third, even a bowel injury can be diagnosed because pneumoperitoneum, we told you last class itself, even small amount of air can be diagnosed by a CT. So because of all this, if the patient is stable enough to wheeled to the CT room, you can do. If the patient is unstable, don't do CT. Patient after ultrasound goes straight to OT. So CT is done only if a patient is stable. That is a very important thing. So here is a patient, right side, this is the left side. As you can see, the patient is having an injury of the spleen, shattered spleen, perisplenic hematoma, extravasation of contrast. Okay, so active bleeding can be diagnosed by a contrast CT. Second, liver also can be injured. How badly the liver is injured, whether both right and left lobe are injured, whether there is any other additional retroperitoneal injuries, like here as a left kidney is shattered and a spleen, left renal vein is also avulsed. All those things can be clearly seen. Also, there is an associated small injury to the liver. Everything can be seen by a cross sections. So CT is very, very important for assessment of all stable patients in trauma. If you know that, that is well and good. What about a word about DPL? Because diagnostic peritoneal lavage was very, very important before the era of the fast scan, that is a ultrasound in the emergency department. But now with the ultrasound available in every emergency department, we seldom do this procedure. That is the first thing you should do. Rarely we do. But why we do? If the ultrasound is not sure whether it is a blood or just a fluid, or patient is having a soft abdomen, or unconscious patient not having any rigidity, you want to assess the patient in a paraplegic patient or a head injury patients. Before you transfer him to the neuro center, the neurologist want to know whether the patient has any abdominal injury. Categorically, I want to know. Then you can do a diagnostic peritoneal lavage, wherein you put a small needle in the peritoneal cavity, instill 1 liter of warm saline. After a few minutes, you just put the bag down. By gravity, the fluid inside will siphonage outside, will come out, and you look at the fluid. If there is more than 10 ml of frank blood, or if the fluid sent shows any of this finding, that is a positive peritoneal lavage. This used to be very, very important postgraduate question, but nowadays, as I said, DPL itself is seldom done. So I don't think you spend a lot of your gray cells trying to memorize this. But if you're a prize candidate, yes, more than 1 lakh red cells, 500 white cells, or presence of bile, bacteria, especially the enterobacteria or food particles, or amylase level more than 175 is indicative of injury to the either the bowel or solid viscera. So you have to do a laparotomy or laparoscopy. So this was used to be a very, very important thing. But as I said before, DPL is seldom done. Okay, we don't do what we call a 4-quadrant aspiration. Just put a needle blindly and we don't do. Only if at all, ultrasound in all cases, CT in stable patients. Rarely we do in a patient with a head injury or a spinal injury before transferring to the neurologist unit. If they are insisting, we do a DPL, and sometimes we do a diagnostic laparoscopy also. Okay, for completion's sake. Let us spend some time on the very important essay sometime last time, blunt injury abdomen overall management, with the management of splenic injury. They ask you, you spent introduction like what we just said, 1 or 2 pages, and splenic injury itself, you write 2 pages. 1 page full of all the findings which we are about to tell you. The spleen can be very easily injured, not only because of road traffic accidents, fall from a height, assault, or iatrogenic also you should remember, never forget. Even during a surgery, because of its close proximity, you know, the spleen, stomach are neighbors. Gastrosplenic ligament, the short gastric vessels are attaching. So when you are pulling the stomach, it can cause avulsion of the spleen also. Or the splenic flexure or the colon also very close to the spleen also. So colonic mobilization when we do a left hemicolectomy or a splenic flexure mobilization during any large bowel surgery can give rise to injury to the spleen. So these are the two things. Third, pancreas surgery also can give rise to splenic injury. Spontaneously, when you suddenly can the spleen go for rupture, at least there are two causes for rupture because the spleen becomes so enlarged, soft. Infectious mononucleosis or a malaria used to cause a spontaneous splenic rupture. So a malaria patient suddenly becomes collapsed. You think of whether the patient is having a hemorrhagic shock due to splenic spontaneous rupture. So these are all the causes. But never forget the anatomy of the spleen in order to understand the surgery as such. Because even though you're undergraduate, there are 3 important anatomical points you should never forget. 1. So spleen is closely related to 9, 10, 11th rib. So because of that, any fracture of the left lower ribs, there is a likelihood of injury to the spleen. That is the first important thing you should all realize. The second thing is the spleen is very closely associated to the tail of pancreas. So when we do a splenectomy, the tail of pancreas should not be injured. That is the second important thing. The third important thing is the spleen has the blood supply, the splenic artery, which is one of the 3 vessels from the celiac plexus. The splenic vein forms the portal vein along with the superior mesenteric vein, portal system. So these two have to be carefully ligated at the hilum of the spleen during the surgery. Nowadays, we do both laparoscopic and also open splenectomy, but ligation of the splenic vessel is very, very important, pedicle ligation. Okay. Let us see from the undergraduate point of view what is important. When a patient is in emergency, what would be his complaint if there is a splenic injury? He'll say severe pain. He might have a complaint distension of the abdomen, giddiness because of the hemorrhagic shock, chest pain because of the fractured rib on the left lower chest wall. So these are all the non-specific symptoms. What will you examine in a splenic rupture patient? When you see a patient with a significant bleeding in this because of splenic rupture, patient will be having a hemorrhagic shock. Very important. Patient will be pale and hypotensive. On the inspection, if you see, occasionally they can have a Cullen sign, ecchymosis in the umbilicus. When you palpate, patient may be tender, okay, where a tenderness usually in the left upper quadrant, and also they may having some tenderness or pain over the left shoulder tip. That is because of the referred pain. When you feel here in the left upper quadrant, they may say, sir, I have a pain also because of the referred pain through the irritation of the diaphragm. That is called a Kerr sign. Very, very important sign to remember for undergraduates. Next, when you percuss, then there will be blood in the peritoneal cavity. So shifting dullness present, very often associated with a clotted blood in the left upper quadrant, perisplenic hematoma. So they have a sign called a balance sign. What is balance sign? Balance sign is present in a case of splenic rupture. Here, when you are trying to demonstrate shifting dullness, patient will be having a shifting dullness on the right side, no shifting dullness on the left side. Why? Because patient has a fluid blood on the right side and the clotted blood on the left flank. Very simple way of explaining. Okay, 3 lines. Very simply, you master this explanation. Then auscultation, bowel sounds may be sluggish. Spleen can be injured just with a small hematoma within the capsule, subcapsular hematoma, or a small laceration. Accordingly, it is graded from grade 1 to grade 5. Grade 4 and grade 5 are very serious injuries. If you know that, well and good. Grade 4 are like avulsion of lower or upper pole, and grade 5 is shattered spleen with the injury of the hilum of the spleen. That is a very severe injury. Grade 4, grade 5 are invariably need surgery. Other grades can be managed conservatively. That if you know, that is well and good. And any investigations, I told you Humpty number of times, always write hematological, biochemical, radiological. Why biochemistry amylase? Because spleen is very closely related to pancreas. Splenic injury, patient may have pancreatic injury, amylase may be raised. Patient requires blood, so group and cross match all patients with a polytrauma. X-ray, we do all cases, X-ray chest, fracture 9, 10, 11 group can be there. X-ray abdomen can show some sentinel loop or some gaseous shadows, abnormal gaseous shadow in the left upper quadrant. But what is important is ultrasound and CT. Okay. Treatment, what is the treatment? I told you already. If a patient is stable, if the hemoglobin is not dropping, BP is stable, treat the patient, actively observe the patient in the ICU setup, giving them fluid, analgesics, bed rest for a week, then don't operate because spleen is important for us, for our immunity and other functions. When you operate, patient becomes unstable with a drop in the hemoglobin, drop in the blood pressure. What do you do? If it is just a small tear in the spleen, then we can repair it by doing a procedure called splenography. Very rarely done, but it is nice to mention in the exam. Splenography is nothing but repair of the spleen by putting an omentum and suturing that laceration, or putting an absorbable mesh around the spleen, just covering it nicely so that it is not injured any further. Okay. What about splenectomy? That is the commonest procedure done. Removal of spleen for trauma is the commonest operation in emergency we do. Let us see one case of splenectomy.
Here is a patient where we did a laparotomy because patient had a pneumoperitoneum as per the ultrasound and CT, and there was suggestion of injury to the spleen. So we did a laparotomy where, as you can see in this picture, the spleen has been mobilized and delivered. There are multiple lacerations in the spleen, and one of the laceration was going right to the hilum of the spleen, and in those situations it is very difficult to preserve the spleen. As you can see clearly in this view, the extent and severity of the laceration. So this patient underwent splenectomy. The spleen was sent for histology, and the hemostasis is confirmed, and there is an associated small contusion in the transverse colon, but there is no injury to the mucosa. Here,
so like that you just witnessed. So what I need to tell you as far as the splenectomy is concerned, midline incision, examine the abdomen completely, thoroughly examine. Not only the spleen may be the source of bleeding, other organs also examine. Look at the solid and also hollow viscous, also look for any perforation or injury or contusion. Once you know this is the only reason for the patient's deterioration of condition, then think about mobilizing the spleen, removing the spleen by ligating the splenic vessels, but at the same time safeguarding the hilum of the spleen so that the tail of pancreas is not injured. And the splenic injury, after that you put a drain there and then come out. Post-operatively you watch the patient, because there are 2-3 complications can happen these people. One, of course, is patient goes for a gastric dilatation ileus, so you need to keep the patient nil orally for a few days. Second, because of the dissection is mainly below the left dome of diaphragm, patient may have some atelectasis and a decreased lung function on the left side, so chest physio may be required. Third, rarely pancreatic injury may cause a ductal rupture and pancreatic fistula. That has to be managed conservatively for with a drain kept in that place for longer duration. So these are the three common complications I would expect undergraduate to write in the exam. The next important thing is, as I said, a burst injury or a blunt injury can cause a pneumoperitoneum because of the enteric perforation. Either a small bowel, stomach, or rarely even the large bowel can also go for a perforation, hollow viscous. So hollow viscous perforation can give rise to a large pneumoperitoneum like this. CT is better, ultrasound is of no use, and if there is a pneumoperitoneum, don't wait any longer, immediately operate. The next rare condition you will see is a evisceration of the bowel. Bowel hanging, coming out through a small hole, quite common. Okay, evisceration of bowel, that is called. If patient is coming after like a bullhorn injury, okay, and then if we see a bowel, don't try to push them in because very, very difficult in a tense abdomen. All you need to do is you just strap that area, cover that area with a moist towel, a sterile towel, and stabilize the patient, give adequate analgesia, and shift the patient to OT. And of course, the patient needs 100% surgery. Okay, the thing you should not do is trying to push things back in, trying to suture it. Okay, so this is a surgical abdomen, evisceration of the. So if the patient has a clinically a peritonitis or bowel hanging out or momentum coming out, or a patient has a persisting hypotension, don't wait. Don't wait for a CT scan. Immediately go for a surgery. And so things like this are very rare, but you'll see once in a lifetime. Okay. So impalement injury like this. A patient was traveling in a bus. One of the iron rod from the another van, when it was colliding with this bus, actually impaled not only through the bus, but also through this patient like this. So all these such patients are coming also. You should be able to bravely counter this patient as far as the emergency is concerned, how to get the patient onto the patients on the operating table. In other words, primary survey, resuscitate the patient, secondary survey, investigation, and then definitive care. So you don't go for any shortcut. How to triage to get the patient safely, okay, out of the vehicle into the definitive care center, that is to the hospital. See how many people, teamwork, one word, but here it will explain clearly. So how many people are there in order to make the patient. And you see the very important thing, nobody is worried about the rod, venous access, airway, breathing, circulation. Then evaluate the patient with a CT scan because you don't know the trajectory. This may be going through the right side, means liver, kidney, diaphragm, whatnot. So then you definitive care. Of course, impalement injury and evisceration injury, they all need surgery. So you have to take the patient under anesthesia and remove not only the impaled object, but also repair whatever is injured in this patient. So all these foreign bodies or cloth and everything will be removed. And then, of course, this patient was little lucky in the way it didn't penetrate. So you can see a liver just laceration. That small diaphragmatic injury was there. That was also repaired. You can see a lung peeping through. See lung, diaphragm, liver, and everything is sutured. All these dead tissues or damaged tissues are debrided. Thorough wash is given. A chest drain is kept. Wound is closed. So, in other words, whatever may be the extent of injury, if we stick to the principles of surgery like hemostasis, prevention of sepsis, removal of all the necrotic, dead, obviously dead tissues, then everything will heal. And post-operatively, of course, with appropriate antibiotics, analgesis control, and anticipate the complication here, for example, because of the nature of injury, patient go for a chest collapse and then atelectasis and a chest infection. So you may have to give a physiotherapy. So this is the intercostal drainage, additional drainage in the liver region, close of the large wound, okay, like this. And you treat the patient, of course. This is a life-saving procedure and once in a lifetime you do, but if you go systematically, these people also, even after removal of these types of objects, can still have a smile in their face. So that is what all about surgery or a surgical practice. So let's stop here with a high note and let us ask any questions from you. Then we'll go back to 5 MCQs and finish well within the time. Yes, Gautam, Diksha, we'll get some newcomers. Unmute and ask either a comment or questions or additional points are very welcome. Dr. Carmagan, how are you?
Fine. Thank you.
Any additional points, Carmen, with your, I am sure you would have seen several of the Splenic. 1 or 2 points from the undergraduates. Anything I overlooked or missed, please add for the benefit before we go in for the questions. Carmegam is from Elagoil, very senior surgeon. Yes, Carmegam.
One thing I want to add is that in controlling the liver injuries, Hegarth-Pringles maneuver can be
yes
added. That is clinching the butt.
That's right. We discussed last class, Pringles maneuver. I'm sure that word everybody will be familiarized. I told you the foramen of Winslow last class. So there you just pinch cock mechanism, because you know both the hepatic artery and also portal vein can be controlled. Especially temporarily, you can minimize the bleeding. That is called a Pringles maneuver. That is nicely brought in the time. So in trauma, when we do a laparotomy, that is very, very important in the liver injury. Yes.
Similarly, for splenic injuries, press the splenic artery over the superior border of the pancreas by opening the lesser sac, gastrocolic omentum.
Yeah, that is usually done for a massive spleen, elective splenectomy. We do that, but in an emergency situations, we go straight to the offender. Most of the times, we don't go for that procedure. So the elective splenectomy, when we do control the splenic artery, then it is much easy to tackle the vein. So that is a good suggestion, Carmichael. Anybody else want to ask Arun, Jagan? If there is no further question, let us go straight to the 5 things. Whoever wants to answer, let me just. Can you see the screen now? I hope. Carmen, can you see this question?
Yes.
Yeah, I lost them. Okay, who wants to give answer now? Key aspects of ICD. Find the wrong statement. I have given 5 statements here. As far as the ICD is concerned, for your own benefit, I read it for you. Place the ICD through the triangle of safety. Incise along the lower border of the rib. Blunt dissection with the index finger is advisable. Bigger drain is always better drain. Connect to underwater seal. This may not be an important question for undergraduates, but very, very important practical things. Anybody wants to answer?
Sir, B, sir. Incise along the lower border of rib.
That is a wrong statement.
Yes, sir.
Well done. Who is this?
Kadiravan, sir, from Perundari Medical.
Kadiravan, well done. So you've done it right, because you have already understood the triangle of safety. This is the triangle of safety as this picture. That is the in between the lateral edge of pectoralis major and the latissimus dorsi, above the 5th rib. This is the area with only intercostal muscles. If at all serratus anterior is there, you can very easily enter here. But you need to enter through the upper border. Why not lower border? Because you know the blood vessels and nerves are along the lower border. So that is the importance of applied anatomy. So always go somewhere here, not here. Well done. Okay. Next, cause for Cullen sign. Choose your best response. I have given you 5 responses. Which response you will choose? Anybody? Yes. Karshini. Yes. Yes, go on.
Sir, all of the above, sir.
All of the above. Let me see. Yes, you're absolutely right. In other words, Cullen sign is not pathognomic of any particular condition. It can happen any massive retroperitoneal bleed or even intra-abdominal situations. But one of the common thing we see is a ruptured ectopic, but other conditions also known depending upon the age group and where you are practicing. All of the above. Well done. So this is the Cullen sign, and this is a Gray Turner sign. Okay. Ecchymosis in the umbilicus, Cullen sign. On the sides, on the flanks is a Gray Turner sign. Define Flail chest, which is the right answer. You can see a multiple small fracture here, fracture. You can see fracture. Subcutaneous emphysema, air packets can be seen even in the supraclavicular.
These are
Very
fractures
classical
ribs.
presentation of a Flail chest, but yes, that
These are fractures ribs.
is. And Dr. Karshan, is it?
Ragadarshini, sir.
Okay, Ragadarshini, well done, very well done. Fracture ribs, because fracture ribs only gives you that Flail segment, giving rise to the paradoxical movement. Very well said, Ragadarshini. Signs in splenic injury are as follows. I have given you some signs here, and except which is the wrong sign here. This is a very difficult question.
Dance sign, sir.
Yes, you got it right. Because you know dance sign is present in which condition?
Interception, sir.
But do you know what is Sissinger's sign or O'Connell sign?
No, sir.
See, without knowing that, because you are sure that dance sign is not because of spleen, you are able to click. See, that is the way of MCQ. Sometimes in MCQ, not necessarily you should know all the responses. With a bit of a luck, that is, in other words, where you are strong, I am sure splenic injury will not cause dance sign. Then you click it. So like that, this is the one thing, but I just want to go back again. O'Connell sign is nothing but a Kerr sign in a Trendelenburg position. See, when your patient is in a Trendelenburg position with a head and leg up position, what happen? The fluid easily go and collect under the diaphragm. So the patient gets early Kerr sign. Kerr sign, even if it is not absent, you put the patient with a Trendelenburg position. That time patient will complaining of pain over the left shoulder. That is O'Connell sign. Sissinger's sign is a sign where you just press the left sternomastoid muscle. So that causes splenic nerve stimulation, that causes pain in the left upper quadrant apparently, or a diaphragmatic spasm. So these are the very, very rare sign, but has been attributed. Splenic injury is so common. So I thought you should also see these two rare signs also if you are a prize exam going. But what you said is absolutely right, full mark to you. This is another rare prize exam question. Anybody knows this particular sign and what I'm trying to depict in this CT? This is a type of a bread here. This is actually quite common in UK. This is called cottage loaf sign. Okay, it's like one bread, you get another half bread free, like that you can have French cap, something like that. So you have the liver herniating through the right dome of diaphragm, like this. So this is actually a rare case of right diaphragmatic hernia. A traumatic diaphragmatic hernia is more common on the left side, almost always on the left side, rarely only right side because of the liver. But sometimes if there is a tear, the partial herniation of the liver will give you a peculiar appearance of this cottage loaf. That is called cottage loaf sign in CT. So that is the final MCQ. So thank you very much, all of you. We'll come next week, coming to another important essay on portal hypertension, wherein we'll be discussing various causes for upper GI bleeding, esophageal varices, hepatorenal syndrome, how to examine a case presenting with splenomegaly or massive ascites with a chronic liver disease, and a short notes on spontaneous bacterial peritonitis. Till then, goodbye. Stay safe. Thank you.